Hey everyone, welcome to CSC Review. We're going to get started with the sim tonight on a neonate. We get a lot of requests for a neonate and pediatric information because I think it makes a lot of people a little bit anxious. We've talked about that before. Working with this age group, there's a huge demand. If you go on any of the job boards, or if you check your email and you're registered for any of the job boards, you're going to get a lot of requests for somebody with neonate and pediatric experience. Probably a minority of therapists actually choose to work with that age group. So if you like this type patient and this age group to work with, then you're definitely never going to run out of options and places to live and work. So the first one we're going to work with is neonate number 8 on the Kettering review. We'll just go over it real quick, and then if you want to log on and give it a try, you can do that. I think the tokens are $5 each, and then if you buy more, if you buy 30, I think you get a little discount or something. So they're definitely kind of fun to do. So look at it as not as much work, but as a little game that you're playing to see what you can score, and just try to take your time and don't be too hard on yourself, okay? So this is a process. We have to learn how to choose the right issues and the right information at the right time. It's not just knowing what the appropriate things are to do, it's knowing when to do them. And that's the thing that I think that makes the CSC a little bit more difficult. So we're going to look at a full-term infant that's 3,000 grams that's in distress. The APGAR at the 1 minute mark was 4. At the 5 minute mark, we only gained 1 point, and it was at 5. We intubated the baby with a 3 ET tube. It's normally developed with a scaphoid abdomen. It has an NG tube in place. Bilateral breath sounds are heard and more distinct on the right. The peak inspiratory pressure is 45 on the pressure manometer, and the bag is really hard to squeeze. So something is creating a back pressure and making it hard to inflate the lungs normally, and requiring a 45 millimeters of mercury pressure in order to deliver the tidal volume that we have in mind. So something is causing us to have to work a little harder. So let's see what that might be. The first thing we're going to do is suction and listen to breath sounds. We hear that it is decreased on the right and absent on the left. We perform transillumination. We get a halo sign on the right, so that's normal. Then we slide over to the left side and we get a bright jack-o'-lantern sign. It is all lit up and shining brightly, so we know there's a pneumothorax involved. It's never normal for the chest to light up like that, so there's air between the chest wall and the lung. So the doctor says, well, what do you recommend we do there, RT? And RT says, well, let's insert a chest tube. The MD inserts a number 5, and the physician asks, where do you recommend that we place the chest tube? And the RT responds, the left midclavicular line to remove air in the second or third intercostal space. And he lets the doc know that if it were fluid, then due to gravity, it would be in the lower lungs, and we would need to place the chest tube in that area. But since it's air, we're going to go with the second or third intercostal space. So we go ahead and assist the physician to do that, and 4 hours later the condition is stabilized. There's unilateral chest movement and scaphoid abdomen. Breath sounds are heard throughout the right and the left upper lung. We get a chest x-ray. During our assessment, we choose chest x-ray and we see there's a mediastinal shift to the right. So something is occurring on that left side and pushing the trachea and the mediastinum toward the right. So we know that if it's pushing it away from the affected side, then we know it's happening on the outside of the lung. So there's a left upper lobe radiolucency with vascular markings, consolidation in the lower left chest, and a normal cardiac shadow. So we've got something occurring on that left side. It's pushing everything to the right, and it's showing as some type of consolidation on the bottom left side. So we have vital signs are 97.6 temperature, so that's okay. Our heart rate's 148, respiratory rate's 31, keeping in mind that infants' vitals run a little higher as far as heart rate and respiratory rate than the adult. So the blood pressure is 62/39. We also need to check the serum glucose level, make sure that it's normal, and it is, but make sure that you grab that point for checking and making positive that there are normal results. The umbilical artery catheter ABG, we get a pH of 7.38. That's within normal range. We look at the PCO2 is 37, so the baby's ventilating okay. The PO2 is 63. So that's a little low. Bicarb is -21 and the saturation's 92. So according to that chest x-ray, the breath sounds that we're hearing and the transillumination, we know that there is definitely an issue on the left side, and then we find out that there's a diaphragmatic hernia. And that's basically when there's a tear in the diaphragm and the bowels actually go up through that tear and put pressure on the outside of the lung, and that's what's caused our mediastinal shift to the right. So how can we correct that? The best way to correct that is with surgery. So we need to schedule surgery, and it will be done to correct and place the bowel back in the abdomen and repair the hole in the diaphragm. The only thing I didn't mention that we should go ahead and check is the serum electrolytes. Go ahead and grab that point as well, and those are actually normal, but it's always good to check them. So we've got our baby stabilized and going off to surgery, so we want to make sure that we're able to recognize what normal transillumination will give us, which would be the halo sign. If it's abnormal and there's a pneumothorax, we're going to see that bright lit jack-o'-lantern sign. And then we're going to opt if it's air. Another point of this CSE is that you know that you would put that between the second and third intercostal space. And remember that if it's some type of fluid, we would put that down lower. And then we want to make sure we've got bilateral chest movement, and in this baby we did not. We had that mediastinal shift. Keep in mind that if it's on the outside of the lung, remember it's going to push that mediastinum and trachea away from the affected side. Okay, so that pretty much takes care of neonate number 8. Let's look at neonate number 9 while we're talking, and they're giving us a 4-week-old baby that was born at 30 weeks. So we've got a preemie, and we're going to find out what's wrong with this preemie, other than the fact that they're 10 weeks early. 38 weeks to 42 weeks are okay, but we'd like to see them stay 40 weeks, but 30 is definitely pushing it. Of course, they survive daily, being born at 27 weeks and sometimes even before, but these causes problems later in life, as far as health problems, and they've just not had enough time to develop, so there may be learning disabilities and things like that, so they really have to be monitored for a very long time when they're born this premature. Now this baby weighs 1,675 grams. They're currently on a nasal cannula with a saturation of 93%. This baby's being tube fed. The birth weight was only 1,200 grams, so it's gaining a little weight. We need to learn everything we can when we're doing these NICU babies, and to find out their history. Everything that you can learn about the labor and delivery will just help you decide what issues the baby's having. And so the LS ratio was 1:1, which reflects the maturity of the lungs, so it was a bit abnormal, of course. The baby was born at 30 weeks, so the respiratory rate is 50 breaths per minute. We're going to choose to check the heart rate as well. It's 120 beats per minute. The temperature is 97.7, so we're doing okay there. Blood pressure is 50/30. The baby is pink with no cyanosis, so that's good. It's currently stable. The chest appearance is bilateral, equal breath sounds with no retractions, so that's wonderful. The RT care plan over the last 4 weeks, we need to know everything we can about the history, like I said, of these children. It got 2 doses of surfactant upon birth, and that's pretty believable to be born at 30 weeks. Sometimes they get up to 4 doses, and remember, we intubate the baby to give surfactant, and we put the surfactant directly down the tube at the prescribed dose, and then we turn the baby from side to side and differently as we do the dose of surfactant, and then we wait in between. And we have a care plan mapped out on how often and how much we're going to give that baby. So after the surfactant was given, the baby was on the vent for 8 days, 4 days on nasal CPAP, and then was weaned from the nasal CPAP to 6 days on a high-flow nasal cannula, and then 7 days on a low-flow regular nasal cannula for an infant. So that's okay. We've had some good success there, weaning the baby down from the ventilator to CPAP, then high flow nasal cannula, and then to the low flow. So things are looking up. There's vesicular normal breath sounds, slightly diminished in the bases, and we're going to go ahead and try the patient on room air. So 4 hours later, you're called to the baby's bedside because she's having 20-second apneic spells. That's never good. So her heart rate's only 95 and her saturation has dropped to 80 to 85% during the apneas. So the doctor says, what does the RT recommend? We want to administer caffeine citrate as a respiratory stimulant, which will also prevent future events. We want to provide tactile stimulation before we do that, which will stop the apnea and restore normal oxygenation and ventilation just by stimulating the baby to start breathing again. Baby's respirations increase when you flick her feet, and her heart rate goes back to the 135 range, and her saturation is back up to 94, so we're happy with that. The doctor says, well, what is the diagnosis? What do you think's wrong with this child? And you say, well, she has apnea of prematurity. She was born at 30 weeks, and so we need to definitely prepare for her trip home. A little bit concerned anytime that the baby has an apneic event while in the hospital. So if they have apnea, then they are held in the NICU until they have not had an apneic event in the last week. So 2 weeks later, the baby has not had any more apnea events. They're going to let her go home. She's been on room air for 2 weeks, and the doctor says, what do you recommend as a home care plan? And the RT replies, let's continue caffeine therapy. Let's do NALS training for the family in case something does occur. They are prepared. And then let's get a home cardiorespiratory monitor. And what they mean by that is let's get an apnea monitor and teach the family how to use that. And so I used to work for a home care company, one of the bigger ones in the country. I worked in the southeastern Kentucky market. And so in the middle of the night, that was back in the day, beepers. So in the middle of the night, I might get a beep and have to go to the hospital because they've brought a baby in through the emergency room that has had some apnea, and they want a monitor placed on the baby while it's in the hospital. And so I'd go in and do a quick in service for the nurses, set the monitor up, put it on the baby, and then starts recording as soon as you turn it on and put it on the baby. And you just set your high and low heart rate alarm and your high and low apneic interval alarm. So you'd always want to put that like on 15s or 20 seconds. The doctor has to write a specific order for the high and low heart rate and the apnea alarms. So we'd have that set, and then there's electrodes you can place on the baby, or there's a band that you can place around the chest that notes chest movement. So they would want that in place while the baby was in the hospital, so it would alarm and alert the nurses and alert the parents or caregivers. And then before the baby went home, I would return to the hospital and do a family session if they were discharging the baby with a apnea monitor. The problem was they would discharge these children and they would go home with them, and then I would get a call in the middle of the night saying the alarm is going off on the apnea monitor saying that it's full and needs downloaded. So I would have to take the laptop out to the home and download the monitor, but it goes off early, so it gives you some time to get out there, so might not necessarily have to go out that night, but it gives you a couple days notice saying you better get out and download this, so if you want all the memory for the printout. So it would aggravate the parents by going off occasionally after it was reset, but I would go out early that morning if I didn't go out that night and download the apnea monitor and then reset the memory, and that would allow them to have some peace and quiet unless the baby had an apneic event. So I got to do that in a lot of different hospitals in southeastern Kentucky. The first year that I had my kids, because we adopted my children in 2000. So the first year I had my kids, I spent the first Easter in a little hospital in Pineville, Kentucky, setting up a set of twins on apnea monitors. But it was a neat job. It required a lot of on-call, but it was highly leaned toward education and patient assessment and making care plans and things like that, making sure that the family was aware of how to take care of the equipment. So there's lots of options for future jobs out there that you might be open to, so keep your mind open and keep studying. Thanks for listening.